Welcome to this deep dive. We're here to break down complex topics and really get to the heart of the matter. Today we're tackling brachiocephalic arterial disease. Okay, so let's picture this. You've got the main artery coming off your heart, the aorta, and it arches over. Branching off that arch are these crucial arteries, the innominate, subclavian, carotids feeding your arms and head. Brachiocephalic disease is when these arteries get blocked up or damaged somehow. And while it's tricky territory, often involves multiple vessels. Figuring out how to even get in there, the access is a challenge. Plus, there are risks, right? Like bits breaking off, causing a stroke. That's a major concern.
Absolutely. And historically, the approach was pretty heavy duty. We're talking open surgery through the chest, high risks involved back then.
Yeah, I bet.
Then came extra anatomic bypasses, less invasive for some, sure, but maybe not as durable long term.
Right. So that leads us to now. Endovascular techniques. These have really changed the game, haven't they?
Oh, completely. They offer more options, often with, better outcomes, lower immediate risks, definitely faster recovery times. It's a huge evolution.
So our mission today is to really dig into how these endovascular methods are used for this specific disease, using Rutherford's vascular surgery as our guide.
Exactly. And it's not just about the fancy techniques. It's the meticulous planning, the patient selection, understanding who really benefits. That's key.
Okay, let's start with prevalence. How common is this? Seems like a lot of our understanding comes from those older open surgery days.
That's spot on. Since open surgery was the standard for so long, yeah, a lot of the epidemiological data stems from those reports. We know, hands down, atherosclerosis, that plaque buildup is the main driver here, the usual suspect, as you say.
Right. But just how often are we seeing it? I read something about a link with carotid disease further down.
Yes, that's a definite link. Yeah. If you look at patients who already have disease at the carotid bifurcation in the neck, somewhere between, say, 5 and 15% also have issues in these arch vessels.
Wow, that's quite a jump.
It is. But if you flip it, people who only have the arch vessel disease without the carotid issues, that's less common, maybe 1.5 to 2%. So it often clusters.
Makes sense. And what about heart disease? Same connection.
Yep. Similar pattern. Patients with coronary artery disease, they have a higher chance, maybe 4 to 7%. And if it's a significant heart disease, that number climbs over 11%. It really highlights that this stuff doesn't happen in isolation.
Like problems in one part of the plumbing signal potential issues elsewhere. Okay,
Yeah.
so which specific artery gets hit most often?
The left subclavian artery feeding the left arm, that's the most frequent one. After that, it's pretty much a tie between the innominate artery, which splits to the right side, and the left common carotid. Both are involved maybe around 30% of the time. Left side seems a bit more common.
Interesting. Is it always plaque? Or are there other causes too?
Atherosclerosis is definitely king, but no, not always. You can also see this with things like Takayasu arteritis, that's an inflammatory condition, or radiation injury, maybe after cancer treatment, aneurysms, dissections. Those can cause problems too.
Okay, so a few other possibilities. Now, planning. Imaging must be absolutely critical for these endovascular approaches.
Oh, crucial. You start often with duplex ultrasound. It gives you flow velocities, so you get an idea of how tight the stenosis is, sometimes see calcification.
Good starting point, but maybe not the full picture.
Exactly. It's non-invasive, easy, but the detail isn't always there for planning an intervention, especially those proximal lesions, deep in the chest behind the collarbone. Ultrasound struggles there. Sometimes a blockage high up just shows as like low velocities further down.
Right. So for the detailed map, you need CTA, MRA.
You got it. Computed tomography angiography, CTA, and magnetic resonance angiography, MRA, those are the workhorses for visualizing the arch anatomy. Big plus is they use axial imaging, lets you see cross-sections without poking around in the arch with catheters initially, which is safer.
Safer, definitely. What do these scans tell you?
Everything, really. Aneurysms, occlusions, how bad the narrowing is, the shape of the lesion, the whole vessel layout. MRA isn't quite as sharp on calcification, but both can show intracranial circulation too.
And those cool 3D models, they come from this data.
Yep. We can reformat the CTA or MRA data into 3D models. Fantastic for visualization, taking precise measurements, really helps plan the procedure.
I can see that, especially since everyone's anatomy is a bit different, right? Like that bovine arch.
Exactly. The classic setup is 3 main branches. But in maybe, up to 20% of people, the left common carotid comes off the innominate artery. That's the bovine arch. And there are other variations left for vertebral artery coming straight off the arch, weird subclavian origins. Knowing these variants beforehand is vital. It really changes your approach.
So anatomy isn't standard. What about older folks, maybe with high blood pressure?
Yeah, good point. Elderly patients, hypertensive patients, their arches are often elongated, more tortuous. The branches might even originate further down, sometimes off the ascending aorta itself. That makes navigating from the groin, from the femoral artery, more challenging. A longer, windier road, like you said.
Longer, windier road. Got it. Seems like CTA might have an edge here.
Often, yes.
Ah.
CTA gives a better look at surrounding structures, and it's definitely superior for seeing calcium. Given how important calcium is in this disease, the recommendation is pretty clear. Every patient needs contrast-enhanced axial imaging pre-op, and CTA often provides the most comprehensive picture.
Okay, so axial imaging for planning. What about traditional arteriography, the dye injection? Where does that fit?
It's shifted. Used to be diagnostic, but now with great axial imaging, arteriography is usually done during the therapeutic intervention itself. More of a real-time map.
A live roadmap during the fix. Makes sense. But there are risks even with that.
Oh yeah, you have to be careful. Often the disease in the branches is actually spillover plaque from the aorta itself. So manipulating catheters in the arch, you risk knocking plaque loose. Emboli, that's the big concern.
Right, gotta avoid sending clots upstream. How did they do the arteriography safely?
Typically a flush aortogram with a pigtail catheter.
Right.
That curled tip helps it sit safely. We use specific X-ray angles, usually the LAO view left anterior oblique that opens up the arch visually. The catheter tip sits just proximal to the innominate origin. We might even use the pre-op CTA to figure out the perfect C-arm angle.
Using the new tech to guide the old.
Smart.
What about seeing specific branches?
For the innominate bifurcation, where it splits into right carotid and subclavian, the RAO view, right anterior oblique, usually works best. Separates those origins. And for the vertebral artery origins, often a slight head-to-toe tilt, craniocaudal angulation, helps because they usually come off the back of the subclavian.
Different angles for different targets. Okay, let's switch gears to the disease itself. High-risk anatomy, what makes a lesion trickier to treat?
Yeah, understanding the high-risk features is key to avoiding trouble. Rutherford's Table 102.1 lays it out nicely. Favorable things are like a simple stenosis, concentric lesion, vessel coming off the top of the arch, no nasty ulcerated plaque, asymptomatic patient, lesion not right at the opening.
And the unfavorable stuff, the red flags.
Exactly. Things like a total occlusion, eccentric lesions where the plaque is lopsided, vessel coming off the ascending aorta, heavy calcium, ulcerated plaque. Also, symptomatic patients, osteal lesions right at the origin, or plaque really close to the vertebral artery start, those make you more cautious.
That makes sense. Those sound tougher. Explains why technical success rates vary so much. I saw 0 to 40% failure mentioned.
It does. Success varies. The most common spots we treat endovascularly are the origins left subclavian, left common carotid, innominate. Less often, we're treating the innominate bifurcation itself, or origins of the right-sided vessels, or lesions further down the body of the arteries.
And location influences the treatment choice, right? Like subclavian versus innominate occlusion.
Big time. Left subclavian occlusion, often tackled endovascularly, but innominate or common carotid occlusion, historically more often open surgery. That cerebral embolization risk is just higher. And if the disease is really diffuse, spread out, bypass or just medical management might be better. Endo really shines for focal, isolated lesions. Also got to remember those tandem lesions problems in the arch and the carotid bifurcation.
Right. And it's not just the target lesion, but what's nearby, like that vertebral artery.
Absolutely critical.
Yeah.
Treating the left subclavian, you have to know where that left vertebral artery comes off. Figure 102.4 shows you well intervene on one vessel origin. You risk compromising its neighbor. Planning has to account for that, mitigate that risk.
Careful planning, careful navigation. Okay, let's dive into the endovascular therapy itself. Started with balloons.
Yeah, balloon angioplasty alone was the initial approach. Thread a balloon, inflate it, open the artery. Initial success was decent, 80, 95%. But the problem was restenosis. It often narrowed down again, like 25% recurrence within just a year or two.
Not ideal long-term, so stents became the solution.
Pretty much. Primary stent placement, putting a stent in right away, is now the main approach. Bare metal or covered stents.
What's the advantage of stenting up front?
Better control, basically. Manages dissections, residual stenosis, gives more reliable, immediate results, keeps the vessel propped open.
And the results with stents look better long-term.
Generally, yes. Large series show good patency, keeping the vessel open 77 to 100% at 18-24 months. So primary stenting is generally preferred now over just ballooning and waiting to see if you need a stent. Balloon expandable stents are most common here. No big trials directly comparing primary versus selective stenting, though.
So usually stent first, Are there times you'd use a different type of stent, like self-expanding?
Yeah, if the lesion's in the body of the artery, not right at the origin, especially if it's tortuous or the vessel changes size, a self-expanding stent might conform better. On the flip side, heavily calcified innominate disease, there's a worry a stent could get compressed over time.
And covered stents, when do they come in?
Balloon-mounted covered stents are quite useful. Precise deployment, good radial force, maybe less in-stent restenosis. Studies show good results for innominate and subclavian lesions. They're also key for aneurysms or trauma. Excellent acute success, good patency, though sometimes you need reintervention for kinks. Not much data yet on drug-eluting stents in this area. Oh, and importantly, avoid stents where the subclavian gets compressed by the first rib, thoracic outlet issues.
Lots of considerations for stent choice. What about the meds around the procedure? Antiplatelets are key, I imagine.
Absolutely vital. For antiplatelets, there's no specific data just for these arch vessels, so we borrow from cerebrovascular disease guidelines like carotid stenting. Aspirin is standard.
Usually combined with something else. Clopidogrel.
Yes, aspirin plus clopidogrel is the usual combo. Proven benefit in atherosclerosis. Helps in carotid stenting, so we use it here. Thing is, clopidogrel resistance is a known issue. So sometimes ticagrelor or prasugrel are alternatives, maybe less resistance, potentially more bleeding risk though. Those potent GP-IVA inhibitors, not shown to reduce emboli here, might increase brain bleeding risk. So stick with dual aspirin clopidogrel usually. Clopidogrel might stop after a month if there's no long-term need, maybe continue up to 6 months depending on the situation.
Okay. And during the procedure itself, heparin for blood thinning?
Yep. Heparin's the standard interprocedural anticoagulant. Not much data on alternatives in this specific setting. Bivalirudin's been used in carotid work, maybe safer regarding bleeding, but needs more robust data for routine use here. So right now, it's heparin, targeting an ACC-activated clotting time of 250 to 300 seconds. Reversing it with protamine afterwards is reasonable if there's no sign of thromboembolic events.
Got it. Medical management sorted. Now for the nitty-gritty, the actual techniques, what's the planning process like?
It's comprehensive. You need a plan for access femoral, brachial, radial, sheath size and length, balloon and stent type and size, all decided beforehand. After the initial arch angiogram, you selectively catheterize the target vessel. Often simple curved catheters work fine, maybe angled glide, VTAC, Simmons for tricky angles. Complex curves needed for tortuous arches, bovine LCCA type 3 arches, but they carry a bit more embolic risk reforming them in the arch. Once you're in, you image the vessel specifically and do the intervention. Complex catheters can be harder to advance further down the vessel, though.
Makes sense. You mentioned brachial and radial access. When are those better than femoral?
They can be lifesavers for subclavian or innominate lesions you just can't reach well from the groin. Sometimes even retrograde carotid access via neck cut-down is an option, though less common.
Let's focus on the left subclavian most common site. How do you approach that specifically?
Several ways. Retrograde from femoral, antegrade from brachial radial, or even combined. Key goals: preserve the vertebral artery, VA, and internal mammary artery, IMA, flow. Need to know about prior IMA grafts to the heart. After the flush aortogram, you get a selective catheter in, cross lesion with a wire, usually a steerable glide wire. Then you advance a long sheath, maybe 6 or 7 French, 70, 90 centimeters long, up to the lesion over the wire. Might need to exchange for a stiffer wire for support. For tricky arches, you might run the exchange wire way out into the brachial artery for stability. Center the lesion on imaging to avoid parallax. Predilation with a 4 or 6 millimeter balloon helps size the vessel, allows stent passage. Balloon should be slightly smaller than the distal vessel to avoid dissection. It also protects the VA origin and proximal lesions and helps see the distal extent of disease relative to VIMA. Stent needs to cover the lesion fully, restore true vessel size, but not jail the VA origin. For ostial lesions, stent should poke 1-2 millimeters into the aorta. Balloon extendable stents allow post-dilation if needed, within limits, can flare the aortic end with a larger balloon edge. Sometimes use protected stenting sheath through the lesion first for tight spots. For ostial disease, often deploy the stent right at the origin, carefully pull the sheath back. Keep the sheath tip nearby for support.
Protecting that vertebral artery sounds paramount. How do you actively do that?
The pre-op plan have to address it. If you can't guarantee avoiding the VA origin, maybe open surgery is better. If the lesion is close, you can protect the VA. One way is using a larger sheath and placing a tiny 0.014-inch buddy wire into the VA origin. Can even stent the VA origin itself if necessary. The buddy wire can come from the main access or a secondary access like radial. Then you advance the main subclavian stent, usually 0.035 compatible over both wires, stopping just short of the VA origin. Embolic protection devices for the VA exist but aren't routine, low baseline risk, and the risk of inserting the device itself isn't fully defined. Interestingly, in subclavian steel, the reversed VA flow actually provides some natural protection initially after stenting.
Clever. Okay, what about brachial access from the arm? When is that particularly useful?
Really helpful for proximal LSCA occlusions, especially flush occlusions that are super hard to cross from the aorta. Might need through-and-through access sometimes. You get a long sheath in the arm, distal to the blockage. Use a glide wire and angled catheter to cross. Critical step. Confirm you've re-entered the true lumen of the aorta, not dissected the wall. Once wire is confirmed in the descending aorta, advance the catheter. Should get blood return? No return. Probably wrong spot. With confirmation, you deploy the stent, usually 1 millimeters into the aorta. Imaging from the brachial sheath can be tough. Transfemoral aortography can help visualize the origin. A wire left in the arch from a femoral pigtail can act as a fluoroscopic marker for the origin, very handy. Most LSCA occlusions can be crossed, especially bidirectionally, but avoid extensive subintimal dissection in the arch.
And radial access via the wrist. You said it's gaining traction.
Hugely. Started in cardiology, now widely adopted. Low site complications, high success, less bleeding, may be better for kidneys. Proven safe and comparable to brachial for retrograde subclavian innominate work. Good option for obese or elderly patients. Patent hemostasis techniques minimize radial artery thrombosis after down to like 0.9%, even if it occludes, often silent. Limitations exist, though. Radial artery atherosclerosis, tortuosity, loops, device size limits, smaller arteries in women, pre-access ultrasound checks, patency, size, 2 millimeter, anatomy. Modified Barbeau test ensures collateral hand circulation, figure 102.6. Low includability rate, micropuncture access under ultrasound, 6F slender sheath, transradial cocktail, nitro-verapamyl heparin prevents spasm, TR band for hemostasis after.
Radial sounds like a really solid alternative. Now, the innominate artery interventions, you called them the most challenging. Why is that?
Several reasons. It's a large bore but short vessel. Getting a stable platform is hard. Need to preserve that bifurcation into right carotid and subclavian. And the embolic risk hits both carotid and vertebral circulations. Protection can be used, but often isn't from a transfemoral approach. You absolutely need to know where the branches are relative to the disease. LAO view for the origin, RAO for the bifurcation, maybe cranial caudal tilt, distal stent landing zone relative to the bifurcation, stent length critical considerations. Figure 102.7 shows an example.
And just getting into the innominate can be tough because of the angle.
Often the hardest part, yeah. Especially disease origins. Like the LSCA, brachial or radial access can sometimes provide a better angle, better distal visualization. Figure 102.7 again. Through-and-through technique is an option. Snare a wire, pull it out the other access. Second access can place wires or protection devices. Rule of thumb. If femoral access to the innominate origin isn't easy within 15 months, seriously consider switching to arm access. Prolonged attempts are risky. If pre-op imaging shows a tough angle, maybe plan for arm access from the start. Often leave the arm wire distally for a better stent deployment angle. Through-and-through can distort the native angle sometimes.
What about specific carotid protection during innominate work?
If you need protection and femoral access is tough, you can snare an arm wire out through the femoral sheath. Allows catheter from below, guide at the origin. Through-and-through wire gives great support. Protection device can go from arm or groin. Treat lesion from groin over the protection wire. But honestly, embolic risk is often low, so simplest approach without protection is frequently used. With arm access, a femoral wire marker in the arch helps locate the origin. Some surgeons opt for a cervical carotid cut down for direct access and clamping flushing.
Lots of strategies. What about the innominate branches, right subclavian, right common carotid?
Right, subclavian intervention is often harder than left. Visualization issues plus stenosis often occur in that short segment between RSCA and VA origins. Extending a stent into the arch is good for LSCA, but for RSCA, it would project into the innominate bifurcation in RCCA origin. Not good. Disease is often right at the origins. May need that kissing stent technique, figure 102.8, to avoid jailing the other branch. Can do it via single large femoral sheath or simultaneous groin arm access for perfect positioning and visualization. Deploy both simultaneously.
Kissing stents, tricky stuff, and left common carotid interventions.
Usually the origin from the arch itself, sometimes in bovine configurations. Approach is similar to LSCA when it arises from the arch. Use least angled catheter possible. Decide on guide sheath. If access is tenuous due to angle, a buddy wire in the external carotid can stabilize things. Advanced protection device into ICA if needed. Intervene over that wire. Remove buddy wire last. If LCCA origin access is really problematic, got away options. retrograde via neck cut down, or just go to open surgery. Depends on other arch disease, bifurcation disease, prior neck surgery, radiation. Sometimes safer to switch approach.
You mentioned combining endo with open carotid endarterectomy, CEA, earlier. How does that hybrid approach work?
Yeah, it's needed in 5% of CEA patients, but it's a safe, effective option when required. Only treat inflow lesions that are truly flow-limiting CTEMA helps identify these. Strong neck pulse, proximal lesion probably okay, blunted duplex waveform, suggests significant proximal stenosis. The hybrid technique usually involves exposing the carotid bifurcation for CEA, clamp the ICA for protection, then intervene on the proximal common denominant lesion before or after the CEA. Access usually via CCA below the bifurcation disease. Wire across proximal lesion, exchange for stiff wire, angioplast distant. After stenting, clamp CCA above stent but below bifurcation, open artery, flush debris, close. Often do CEA first to avoid stagnant flow in the new stent.
What results are they seeing with these combined procedures?
Generally favorable, but some variability. A 2011 meta-analysis showed high technical success, 97%, low mortality stroke, but more restenosis with angioplasty alone. A 2016 review was a bit more cautious, citing dissection, stroke, death risks, advising use only for hemodynamically significant lesions. But other reviews, 2018-2020, concluded safe and advantageous with good patient selection and technique. A helpful tip: using a pigtail catheter from groin during the inflow stenting part can really help delineate the arch anatomy, which is often poorly seen on retrograde angiography alone. Better anatomy view means better stent placement.
Sounds like a valuable tool when needed, if done carefully. So, stepping back, what are the overall results for brachiocephalic endovascular interventions in general?
Early days with just balloons were limited. More recent studies, mainly with stenting, show low complication rates, good initial success, acceptable long-term outcomes. Stenting is now primary treatment. Table 102.2 shows technical success is high. 94-100% for stenosis, maybe a bit lower, but still good for occlusions. 57-100%. Complication rates 0-20%, mostly access site stuff. Neurologic events like stroke are rare, sometimes in those combined procedures. One study noted maybe higher thrombosis restenosis with longer stents, 40 millimeters. A registry had similar stroke rates but higher VA stenting, which isn't typically recommended. A large prospective study showed high success opening vessels, good long-term freedom from restenosis, low major complications. Mortality and neurologic morbidity are low in the biggest series. Ruptures rare, but possible. Managed like other vessel ruptures, balloon occlusion, covered stents.
Okay. Good immediate results. How does endo stack up against open surgery long-term? Patency rates.
Looks like endovascular patency might be slightly lower than surgical reconstruction long-term. Table 102.3 shows endo 1-year patency around 88-97%. 5-year maybe 77-89%. But if restenosis happens after endo, it can often be retreated successfully. Secondary patency rates after reintervention can be comparable to open surgery. Retrospective studies comparing endo versus bypass for subclavian disease show mixed results on complications and patency. Surgery often has better long-term primary patency. A key 2012 report concluded both are safe, effective, but bypass is more durable. Crucially, failed endo patients could still have successful surgical rescue. So yeah, long-term patency seems better with open surgery. But endo is still very reasonable. Low risk, fast recovery, outpatient potential, preserve surgical options. It's a good first-line approach for many.
Makes sense. Less invasive first, surgery if needed. What about those inflammatory conditions like Takayasu? How does endo fit there?
It's different. You need to manage the inflammation first. Anti-inflammatory meds reduce inflammation, not stenosis directly. Revascularization is trickier due to cell overgrowth, restenosis risk. Aim for quiescent disease, normal inflammatory markers, improve symptoms before intervening. Urgent cases, like acute cerebral ischemia, might force intervention even with active inflammation. Autogenous bypass, using own tissue, preferred then for lower recurrence. Endo and active inflammation. Lower success, higher recurrence linked to ongoing inflammation. Covered stents might help here. After inflammation subsides, assess residual lesion. Endo better for short focal stenosis. Stenting beats angioplasty alone. Complex lesions, long occlusions. A autogenous reconstruction often has lower recurrence than endo. Limited data on covered stents here, but potential role.
More complex when inflammation's involved. Okay, last piece. Long-term management after endovascular treatment. Surveillance.
It's ongoing. Medical therapy for the underlying atherosclerosis is key. Manage hypertension, lipids, diabetes. Smoking cessation is huge. Antiplatelets are crucial after stenting. Aspirin plus clopidogrel initially, often continued for at least a month, maybe longer depending. Optimal duration isn't perfectly defined. Follow-up is vital. There's a 15–25% risk of restenosis within 3 to 5 years, half symptomatic. So history, physical exam including bilateral arm pressures, duplex ultrasound every 6 months for 18–24 months, then annually. If duplex view is poor due to location, CTA can assess stenosis, basically regular checks for the first couple of years, then yearly.
Regular checks keep managing the risk factors. Got it. So wrapping up, endovascular techniques have clearly made a massive difference here.
No question, huge advancement. Less invasive, lower immediate risks, quicker recovery than the old open surgeries. Surgical patency might still edge out long term, but the benefits of endo make it an incredibly valuable tool.
But definitely not simple. Lots of factors to weigh for each patient.
Exactly. It's complex decision-making. Lesion characteristics, patient health, local expertise, it all matters. Needs careful imaging interpretation, deep anatomical understanding, weighing risks and benefits of endo versus open, angioplasty versus stent, access site protection devices.
A really fascinating deep dive. It definitely makes you think, with technology moving so fast, where does this go next? What will managing brachiocephalic disease look like in, say, 10 years?
Right. New devices, maybe better drug therapies, refined techniques. It'll be interesting to see how things evolve to further improve outcomes.
Something for us all to keep an eye on. Well, thanks for walking us through that complex topic today. This has been incredibly insightful.